Welcome again to our STI clinical update webinar for American Samoa, focusing on syphilis, chlamydia, and gonorrhea. My name is Kelly Johnson. I'm the medical director of the California Prevention Training Center, which is at the University of California, San Francisco. We're really excited to be here with you all today and hoping that we can have a really informative and helpful session today. I do have to go over some brief kind of introductory and housekeeping slides before we get started. I've been having some bandwidth issues, so I'm going to go off video to do this, but I'll do it quickly. Okay, so first I'm going to tell you a little bit more about the California Prevention Training Center, or CAPTC, which again is at the University of California, San Francisco. We are a multidisciplinary training and capacity building assistance center. Our STI clinical training is sponsored by the CDC, and we're a member of a larger national network of STD clinical prevention training centers called the NNPTC. What do we do? Well, we provide virtual and in-person training events, technical assistance, clinical tools, and STI consultation services focusing on complex issues in patient care around STIs. And if you want to know more about us or the network we're a part of, you can see these two links at the bottom of this slide. I do want to tell you about one of our primary resources, which is the STD Clinical Consultation Network, or the STD-CCN. The California Prevention Training Center, we run this for our region. It's an online clinical consultation network where providers can go, submit their complex STI patient care questions, and one of our faculty, so our subject matter experts, will reply by either phone or email, whichever you prefer, within 1 to 5 business days. And for you all in American Samoa, I do want to point out, we've double checked this today, you can use this website, stdccn.org, but when it asks for your location, just select Other. Okay, for today, here is our financial disclosure. We don't have anything to disclose. And here's our CME disclosure stating that today's training will be offered at 2.25 CME units at no cost to you. Just a note on our CME credit type. So we are only able to offer CME AMA Category 1 credit for this training. We do want to note that nurses might be eligible to receive CMEs through this mechanism because it is recognized by the American Nurses Credentialing Center, but you can go ahead and click on this website if you'd like more information about that. And because this is our first event in American Samoa, at least in quite some time, if you all find that this type of CME that we can offer is not useful to you, we'd actually really like to know about that and which type of CME instead would be more helpful. So if you have any issues with CME, this is our program manager, Elizabeth Olson. Please feel free to give her an email. We really want to know how this goes today. Now, what do you need to do to earn your 2.25 CME units? We do get a lot of questions about this, so I am going to go over it. So you must have registered for today's webinar on the NNPTC website by 12 p.m. Pacific on August 29th. So registration is now closed. And you do have to attend the webinar live and in full. We'll record your attendance as you sign on to the webinar. And we are unable, unfortunately, to provide CME credit for attending just part of this webinar or if you're viewing a recording of the webinar after the fact. Finally, you must also complete the post-course survey evaluation by a deadline of September 5th. You'll receive a link to this post-course survey evaluation in an email. This email will come within 24 hours after today's webinar, and it will come from this email address, training@nnptc.org, and it will come to the same email address that you used to register for this webinar. To make sure you receive our notification, please add that email address to your safe and trusted senders list, and be sure to check your spam and junk folders if you don't see the email in your inbox. If you meet CME requirements, you'll receive notification by September 30th, and it will come from a different email address. This is our email address, captc@ucsf.edu, again, to the same email address that you used to register for today's talks. The notification that you receive will include a link that you can click on to go ahead and claim your certificate from our CME provider. And again, to make sure you receive your notification, please do add our email address to your safe and trusted senders list and check your junk folders if you don't see this email. Our slide handout and our webinar recording, you don't have to do anything special to request these. We will send these out to you approximately 2 weeks after the webinar. And again, they will come from our email address, captc@ucsf.edu. Now, a little bit about Zoom. I know we're all familiar with it, but for today, the Q&A will be turned on. So if you have questions or comments, go ahead and use the Q&A. To use the Q&A, as you probably know, you can click on the Q&A icon from your Zoom tools. You can type in your question and you can hit send. You can do this anonymously if you prefer. And you can submit questions up to the last 2 minutes of the Q&A session. Now, today's group is pretty small, so feel free to go ahead and have as many questions as you come up with. For microphone, video, and chat, please do remember to put yourself on mute and turn off your camera if you don't want to be heard or seen. Just as a reminder, we are recording today's webinar. And now I'll tell you about our 2 wonderful faculty speakers for today. Our first speaker will be Dr. Sharon Adler. Dr. Adler is the clinical faculty and colleague of mine at the California Prevention Training Center, and she's an assistant clinical professor at UCSF in the Department of Family and Community Medicine. She's worked in the STD field for over 20 years, including 10 years of work at the California Department of Public Health in the STD Control Branch. She is board certified in preventative medicine and public health and has clinical experience working in community health and public health clinics in the San Francisco Bay Area, as well as at the San Francisco STD Clinic. In her current position, as you can see, Dr. Adler develops curricula and she conducts and coordinates STD trainings. Our second speaker covering gonorrhea and chlamydia will be Dr. Rosalyn Plotzker. She's an assistant professor in the UCSF Department of Epi and Biostats and also performs high-resolution anoscopy at the UCSF Anal Neoplasia Clinic Research and Education Center. She completed a fellowship in sexually transmitted infections with the California Prevention Training Center and the California Department of Public Health. And she additionally serves as a public health medical officer in the STD control branch for our state Department of Health. Again, if you have any questions today or issues with CME, this is Elizabeth Olson, our program manager. Please feel free to reach out to her. And without further ado, I will turn it over to Dr. Adler, who will be jumping into syphilis. Thank you all again so much.
Thank you, Kelly. I do not have any disclosures. That was already mentioned. So as an outline to my presentation, and we've had a few emails back and forth and conversations with Dr. Ina Sagada. What my understanding is that you have not seen a case of syphilis in American Samoa for at least about 5 years. And so this hopefully will be a lot of new information and will prepare you if and when syphilis does make its way over to American Samoa, because it is a very common STI. We're seeing a lot more of syphilis in the United States and in many other parts of the world. So as an overview, what I'm going to share with you first is the natural history of syphilis. I'll show a lot of pictures of how it manifests and why it's been called the Great Masquerader, because it can mimic many other conditions. We'll talk about how syphilis is diagnosed, and take-home message here is that you need, to confirm a diagnosis, you need both types of serologic tests for syphilis, the non-treponemal type, which is the common one is RPR, and my understanding is RPR is what you're using, and then the confirmatory treponemal test. And then we'll talk about how syphilis is divided into stages and how staging a patient who presents to you is really important, because staging can influence how you're going to treat your patient, and staging is also important in understanding partner management. And then I'll briefly talk about partner management, but that won't be the focus. It'll be primarily on the clinical manifestations, diagnosis, and staging. All right. And before we launch into all of that, I want to mention what the screening guidelines are. So syphilis goes through a phase where the disease is asymptomatic, and that's called latency. And for that reason, populations that are known to have higher risk for syphilis should be screened. And this is just summarizing what the CDC 2021 STI treatment guidelines recommendations were on screening, along with the U.S. Preventive Services Task Force. So for persons who are not pregnant and men who have sex with women, these populations have known lower epidemiologic risk for syphilis, and so it really is just risk-based screening. Other populations where we have higher rates of infection, particularly men who have male partners, what is recommended is at least annual screening, but most likely more frequent screening, possibly up to every 3 months or 6 months. If there are risk factors, and some of those risk factors might be having multiple partners, anonymous partners, persons who are on PrEP, persons living with HIV, whether they be male, female, trans, should be screened at least annually, possibly more frequently based on their risk, and then definitely at the first evaluation when you're making a diagnosis of HIV. In addition, we know that STIs can people get infected together with multiple STIs. And so if anyone's being diagnosed with gonorrhea or chlamydia in your clinic settings, those persons should also be tested for syphilis. Finally, correctional settings, so places where people are incarcerated, are known to have higher rates of syphilis. And so in general, most correctional settings on intake, so when people are presenting for their, when they're entering corrections, they're often screened. And then I'm not going to be focusing a lot on syphilis in pregnancy, but I want to just mention that in many parts of the United States and many countries, we're seeing a lot more congenital syphilis, and that is where syphilis is transferred from the mother to the baby because the mother is pregnant and she is infected with syphilis. And for that reason, there is state-by-state guidance on how frequent screening should be in pregnancy. In California, we have a lot of congenital syphilis, and we actually screen every three times in pregnancy. The CDC general guidelines are just to screen at the first prenatal visit. So, and then if there's risks, would retest in the 3rd trimester plus at delivery. But I want to say that many states in the United States are seeing higher rates of syphilis, and therefore they're screening 2 to 3 times in pregnancy. And that is the screening recommendations. And screening recommendations are important because, as I said, people can go through a phase of syphilis where they have no signs or symptoms, and the only way that you detect it would be through screening for it. But now we're going to launch on and talk about the natural history of syphilis and the clinical manifestations. So this graphic here on the right shows you, kind of depicts how someone becomes infected with syphilis, and the bacteria that causes syphilis is the spirochete, the Treponema pallidum spirochete bacterium. See something in the chat. I'm wondering if there's a question. No, okay. That's just Kelly putting in something about ACOG screening. And the ACOG recommends screening 3 times in pregnancy in the United States. So the bacteria Treponema pallidum is the causative agent for syphilis, and it is transmitted either by direct contact to an infectious lesion. That is how sexual transmission takes place. Very rarely it can be transmitted bloodborne, or more commonly, as I mentioned, in the United States, it can be transmitted from mother to child at any stage of infection. Syphilis is a systemic infection, meaning that any end organ system can be impacted. And so very soon after the Treponema pallidum infects and causes a chancre, and I'll be showing you what that chancre looks like. Starts out initially as a papule, then it ulcerates to form a chancre, but there is very rapid spread through blood and lymphatics, and therefore here's showing you the CSF, the eye, the ear, the liver, the intestines, the kidneys, the central nervous system, all can be impacted by syphilis. And we'll go on to our next slide. This shows you the stages of syphilis. And so syphilis is extremely infectious. So there are estimates that anywhere between 30 to 50% of people, if they're exposed to an infectious lesion of syphilis, then those people can become infected. Incubation period is on average about a month, but it can be as long as 90 days. And that is important when we talk about partner management at the end of this presentation, to remember that the incubation period for syphilis can be up to 90 days. The primary manifestations of syphilis is the chancre, and I'll be showing you a whole bunch of pictures of that in just a moment. But the classic syphilitic chancre is painless. And so if this is a painless lesion that maybe in a female is in the vagina or on the cervix, or if it's in a male who's engaging in receptive anal intercourse and they're having a lesion in the perianal area or somewhere around the rectal area, if it's painless, they may not recognize it. They may not present for care. And these lesions will resolve on their own over the course of a month or 6 to 8 weeks. Secondary manifestations of syphilis then would occur, and those manifestations, the most common one is rash, and I'll be showing you a variety of pictures of the rash. But as I said earlier, syphilis has been called the great masquerader, and it can masquerade as many other conditions. And the rash of secondary syphilis can look like a whole host of other conditions, including just a viral exanthem from like mononucleosis or another kind of virus. And so these rash lesions, as well as a host of other lesions that can occur with secondary syphilis, will also disappear on their own spontaneously, even without any treatment, over the course of 1 to 2 months, maybe a little bit longer. And then the person is in latency, and that is what this dark blue circle is representing. And that is why screening is so important for syphilis. Approximately 25% of untreated people will go on and have a relapse of those secondary manifestations, usually within the first year of latency. And then the natural history, and these go back to old studies like the Oslo studies about syphilis. The natural history in the pre-antibiotic era was that about 30% of people would then go on to have tertiary. So they can be latent for many, many years. And in the antibiotic era, which is the current era that we're living in, this number may be even less than that in terms of what percentage of people go on to have tertiary disease over the course of years. The other thing I want to highlight on this slide is neurosyphilis, ocular syphilis, and we should add in here otosyphilis, can occur at any stage. And so I used to teach that neurosyphilis, it took years and years for that to develop, and now we realize it can be one of the initial manifestations of syphilis. All right, here are my pictures. So I've got a whole bunch of slides with pictures depicting primary, secondary, all the different manifestations. And so this upper left-hand corner is kind of your textbook syphilitic chancre. So it is a solitary lesion, minimal exudate, so there's not a lot of yellow here. It has heaped up edges. These edges are firm and they're palpable. That's called induration. So this is the textbook syphilitic ulcer. Here's another pretty classic looking syphilitic ulcer. When you have ulcers in extragenital sites or when you have anal sites, these can mimic actually fissures. And so this is a syphilitic ulcer, but it kind of looks like an anal fissure, a large anal fissure, but it's not as textbook like these ones here. This is on the penis. And then here are two examples of how syphilis can mimic many other conditions in that you can have multiple shallow lesions and you can have lesions that have some exudate. And that's what both of these have. And these were actually identified by Darkfield to be syphilis and not herpes. Here are some examples in women. Here again is a very classic solitary ulcer with induration, minimal exudate, not so classic looking chancre, and then a female with multiple lesions and one in the perianal area that can mimic herpes. So when you're seeing someone who's presenting with a genital ulcer lesion, you have to think about other possible pathogens. Based on our current epidemiology, herpes is probably the most common STI pathogen that can cause genital ulcers. And I'll show you a couple pictures of herpes. It's in that differential. Syphilis is in the United States. That's probably the next. Chancroid, we don't see very commonly in the United States. There are a bunch of other STD pathogens, lymphogranular venereum, Mpox, a somewhat newer pathogen that we're seeing in the United States. Acute HIV can present with genital ulcers, as can granuloma inguinale, which is again very uncommon. But there's a whole host of non-STIs. And so all of these things should be on your differential when someone's presenting with genital ulcer lesions. Things to keep in your mind when you're thinking about syphilis is what are the number of lesions? Is it single or multiple, with single being more common, but as I'm showing you, you can have multiple lesions. Are the lesions shallow or deep? Somewhat in between for syphilis. Are the borders smooth or ragged? More smooth for syphilis, ragged for things like chancroid. Is there induration present? Typically with syphilis, there is induration. Typically with syphilis, you have a clean base lesion. Typically it is painless, but you can always get a secondary infection or you can have multiple infections at once. And then typically for syphilis, you have associated lymphadenopathy that is regional, rubbery, and not usually painful. And this is just showing you kind of the textbook manifestations of syphilis, herpes, and chancroid. So syphilis here, it's not ragged, it's solitary classically, and you have this induration. To contrast that with herpes, Classically with herpes, you have multiple shallow ulcerations that are very painful, and herpes starts out with vesicles and pustules. And I'll just show you a couple pictures. So on the right is herpes. This is herpes with the pustules and vesicles. But then you can see here how they've become unroofed, and then you are left with an ulcer. And that is what we're seeing here, is we're seeing an ulcer from herpes after the vesicles have been unroofed. And that's the phase that it might mimic syphilis. And then chancroid, an example of someone who's got chancroid. These are more ragged edged, lots more exudate, a lot more erythema, but these also could mimic herpes. And this is why testing is so important for all these diseases. I want to mention Mpox. I don't know if American Samoa has seen any Mpox. Mpox, previously called monkeypox. The clade 2 of this, there was a fairly big outbreak in the United States, 2022. We're still seeing cases in 2023, but parts of Africa are where this originated. And Mpox, these lesions here do not really mimic syphilis in that they're papules with a central umbilication, the little dot in the center. They might even mimic more molluscum. But if these are unroofed, and that's what we're having here on the right, this lesion here might mimic syphilis. So I just want to mention Mpox. Moving on, so those were showing you kind of all the genital lesions of syphilis, but because syphilis occurs, the chancre or the ulcer occurs at the site of inoculation. If the person is engaging in oral sex, you might have lesions around the mouth, and that's what this is an example of, a lesion on the tongue, on the chin, on the lips, a couple other lesions here on the tongue, in the lip, and then a digital lesion. I would imagine it took a long time for the diagnosis of syphilis to take place for a digital lesion. But what I always like to say is we're really thankful for latex gloves, because prior to latex gloves, if someone had a digital chancre years ago, that was a sign that you were a clinician, because syphilis has been around for centuries, and people were getting infected just being clinical providers. All right, so that was primary syphilis. Now we're going to move and talk about secondary syphilis. And so again, someone gets exposed to an infectious lesion. They may have primary manifestations. If these don't present because they're in sites where the person doesn't recognize them, then the person will go on into secondary. Rash is the most common manifestation of secondary. It occurs up to 90% of the time. When I was in medical school, I was always taught, look at the palms and the soles. If they've got lesions on their palms and the soles, you have to think about secondary syphilis. In addition to rash, patients present, and they present with what could be like a viral illness. They have generalized lymphadenopathy, they have constitutional symptoms, they may have fever, and they may have body aches, they feel unwell, and then they have a really interesting rash. And so take-home message here is anytime you're making a diagnosis of a generalized rash, particularly in somebody who also may have some constitutional symptoms, always have syphilis on your differential, and you should probably be testing for syphilis as well. I will show you pictures of the mucus patches, the lata, and the alopecia in just a moment. And then, as I said earlier, neurosyphilis can occur at any stage of syphilis, and many patients, when they present with secondary manifestations, also have manifestations of neurosyphilis. So here I'm going to now share a bunch of slides that look at the rash of secondary syphilis. And so the classic rash is a copper-colored maculopapular rash. This one here, this could look like pityriasis or tinea versicolor. There's another example, kind of a copper color raised maculopapular rash. Here is in a female patient. Here's someone who's got lesions on their palms. And then upper left-hand corner, this split papule is kind of a pathognomonic lesion of someone who's got secondary syphilis. The rash morphology can pretty much be any morphology, and so macular papular is very, very common. Annular lesions are very common. Annular lesions on the scrotum here. More papulous squamous lesions, pretty dramatic on the palms and the soles. And then this is kind of a lenticular morphology. And then an example on the corona of papulous squamous lesions. So new onset rash in a sexually active person. Please think about syphilis, and then plaque-like lesions can occur. These can mimic psoriasis or other forms of plaque, but these all are secondary syphilis manifestations. So this is just showing you how syphilis can masquerade as other diseases. And so when you're making these diagnoses, please think about secondary syphilis. tinea versicolor, fungal infection or pityriasis, erythema multiforme, which often presents with lesions on the palms. Because of that, secondary syphilis can mimic that. A drug reaction. So many times if someone, particularly someone who's living with HIV, starts a new medication, they may, if they have a drug reaction, we've heard of numerous cases of that drug reaction when it was actually secondary syphilis and it wasn't a drug reaction. So have that in the back of your mind as well. Scabies can mimic secondary syphilis, as can the viral exanthem and psoriasis. This is what a mucus patches look like. These are extremely infectious lesions on the buccal mucosa or on the tongue, gray-white lesions. These are teeming with spirochetes. Oops, sorry, that I didn't mean to advance. Oh, my slides are having a mind of their own. Here we go. So these lesions, so when you're making a diagnosis of syphilis or when you're doing your STI exam on a patient, it's always good to take a look in somebody's mouth in addition to looking to the anogenital area, because that's where you might find hidden manifestations of secondary syphilis. Alopecia or loss of hair is a classic manifestation of secondary syphilis, occurs maybe 25% of the time. You can have diffuse alopecia or loss of hair or moth-eaten alopecia. I was always taught in medical school, if someone has alopecia of their eyebrows or eyelashes, that's pretty pathognomonic for secondary syphilis. And then lata. So condyloma lata can mimic genital warts, but they're not genital warts. This is caused by secondary syphilis. These are wart-like lesions in moist areas, in the anogenital areas. These lesions, if you try to freeze them, if you're going to freeze a wart or use liquid nitrogen on them, they may resolve on their own, but then you would have missed a diagnosis of secondary syphilis. And so I always say when you're making a diagnosis of genital warts in a patient, that's your opportunity to screen for syphilis as well. All right, moving from primary and secondary, I want to briefly talk about neurosyphilis. I think I just have 1 or 2 slides on this. Neurosyphilis, as I said earlier, can occur within a few months to years after infection. It may be the initial manifestation that someone presents to a provider with. Common signs of early neurosyphilis are cranial nerve dysfunction. These are often cranial nerves 6, 7, and 8. So facial and motor weakness, extraocular movements, meningitis, classic meningitis symptoms like headache, stiff neck, fever can be a sign of neurosyphilis, stroke, altered mental status as well. Otosyphilis, and this is where syphilis affects the ears, can lead to deafness. And you can have tinnitus, which is ringing in the ears, may accompany it. Ocular syphilis, a whole host of visual symptoms, including changes in visions, floaters, blurry vision, flashing lights, increased ocular pressure on exam. Any patients who have otosyphilis or ocular syphilis should really be seen by a specialist to help clarify what's happening in these patients. Late neurosyphilis, I'm going to talk about on my next slide. These are patients who meet criteria for tertiary syphilis. Classically, it's TABEs or general paresis, which I'll define on my next slide. Take-home message here is all of your patients who are being diagnosed with syphilis should have a good neurologic exam that includes an assessment of any ophthalmologic or auditory symptoms. Patients who should be referred for lumbar puncture are those who have evidence of an abnormal neurologic exam. And then this slide is available up, I think it's up on the California Department of Public Health website. It's also probably up on the CAPTC website. It goes through kind of early findings, a review of symptoms in someone who you're assessing for neurosyphilis, as well as how to do a good neurosyphilis exam. That part is kind of cut off here, but I just want to mention a resource that's available to you all, that's available on our websites. All right, so tertiary syphilis. Again, this is the timeline here. The natural history of untreated latent infection in the pre-antibiotic era was approximately 30% of people went on to have tertiary complications. Tertiary complications can include Gonorrhoeae disease, and that's what this picture, which is a pretty graphic picture on the upper right-hand corner of your Zoom of your computer is showing you. It's Gonorrhoeae inflammation that can be destructive. The skin and the bone are the most common sites. Occasionally, viscera is impacted as well. Cardiovascular syphilis is a sign of tertiary syphilis. Classically, aortic insufficiency or aortic aneurysms can take place. And then two late neurosyphilis diseases are tertiary syphilis. So TBs is defined by lightning pains or shooting pains that occur from a posterior column dysfunction. Patients can have ataxia where their gait is unstable. They may have paresthesia, so numbness and tingling. They may have changes in their bowel and their bladder function. And then general paresis, which is psychiatric, as well as paralysis and muscle weaknesses, changes in mental status. In years ago, many patients who were hospitalized in psychiatric institutions actually ended up having a general paresis. I'm talking hundreds of years ago, but very known complication of tertiary syphilis in the pre-antibiotic era. All right, so that was kind of sharing with you all the primary, secondary, tertiary phases of syphilis. And now I want to talk about staging. I mentioned at the beginning that staging was something I was going to talk about because staging influences treatment. And so this is kind of an algorithm to go through and determine to assess what stage of syphilis does your patient have, and what stage of syphilis your patient has will impact how you're going to treat them. So someone who presents with a chancre of syphilis gets staged with primary. Someone who presents with rash, alopecia, condyloma lata, mucus patches, that they would get staged with having secondary syphilis. And obviously, all of these patients are being diagnosed with syphilis. You want to do a good neurologic exam. If they have findings that are consistent with neurosyphilis or ocular syphilis, they would get staged with that stage of infection. Patients who you're screening for syphilis, and we'll talk about screening algorithms in a little bit, if based on your diagnostic test, your syphilis serologies, they meet criteria for syphilis, you would want to do a good head-to-toe exam and assess in a history of whether they have any symptoms of syphilis. If they don't, then they would meet criteria for latent infection. So again, latent infection, no signs or symptoms of syphilis, but they have serologic tests that are positive for syphilis. Latent syphilis gets further divided into early latent syphilis, where they meet criteria for being infected for less than 1 year. And so what are those criteria? And these are not things that you need to memorize. These are things that are easily, accessible in these algorithms that are out there. So if someone had a negative syphilis serology a year ago, within the past year, and now has a positive syphilis serology, you have evidence of them being infected within the past year. If they're a known contact to an early case, good history of typical signs or symptoms. If they have a 4-fold increase in titer, in someone who was previously treated and they're currently sexually active, that could be a sign of reinfection. Or in the scenario where their only possible exposure was this year. So it's someone who's newly sexually active, only possible exposure was this year, and now they have positive serologies. They would be categorized as early latent disease. And so why is staging as early latent important? It's important because persons who have been infected for less than 1 year, they can get the same treatment as primary or secondary. Persons who do not meet any of these criteria then get staged as having late latent or latent of unknown duration, and they get different treatment. And when we move to the treatment section, you'll see why this staging is so important. Early latent gets the same treatment as primary and secondary. Late latent gets its own treatment, and neurosyphilis gets its own treatment. So staging, extremely important. And staging is important for partner treatment as well. And when we get to that section, I'll reference back to this slide. All right, so I want to wake everybody up in the room. So we're going to move in to talk about diagnostics, but I'm hoping that you can take a moment and think about how you might manage this case. And I realize that no one has really managed many cases of syphilis, but let's just see what your guesses are and how you'd manage this patient. So here's our patient, Stephanie. She's presenting with a painless sore in her vulva. This is what it looks like. It's a solitary lesion. It has induration, minimal exudate. It's painless. She is somebody who has risk for sexually transmitted infections because she's had 3 male partners in the past 6 months. She also has had gonorrhea and chlamydia. So those are all indications that she might be at risk for all future STIs. She has no history of herpes in the past and no history of syphilis. And you're working in a setting, maybe it's an emergency room setting where you have access to a STAT or rapid RPR. And your rapid RPR is actually negative. So we're not going to poll everybody, but I want you to kind of think in your head, how would you manage this patient? Would you wait for her quantitative RPR or possibly other tests? Maybe you're doing tests for herpes, maybe you're doing tests for chancroid. Would you wait for those tests to determine her treatment? That's choice A. Choice B, would you presumptively treat her for syphilis now just because of how the lesion looks and her risk for STIs? Would you order a treponemal test, a specific treponemal test like the TPPA? Or might you do B and C, which is presumptively treat for syphilis plus order that treponemal test? Or the final option is you wait for your test results to determine treatment and then order a treponemal test. So just think about how you might manage this patient. And then I will share with you how I would say is the best kind of management strategy for this patient. And that is to presumptively treat for syphilis now and get a treponemal test. And we want to presumptively treat because this is a classic textbook syphilitic lesion. It's kind of walking in the door. And so the other thing that's very important that you all need to know is that your serologic tests for syphilis have limitations, and that important limitation in primary syphilis. So when someone's presenting with genital ulcer disease, your test for syphilis might be negative a quarter of the time, 25% of the time. So you have to sometimes presumptively treat as well as test. The other thing that's important to note here is that the RPR test is a non-treponemal test, may have slightly lower sensitivity. And so sensitivity is the ability to detect disease than treponemal tests in early syphilis. And so the TPPA might turn positive earlier than the RPR. That's the take-home message here. And we're going to launch and talk about diagnostics, and I'll show you that kind of on a graphic in a moment. But what this case is demonstrating is if you have someone who has a serologic test negative, that's the non-treponemal test, that's RPR, but your suspicion is high, and in someone who has risk for STIs, someone who has had multiple partners, STIs in the past, and has a lesion that looks like syphilis, you would empirically treat. And then you might get an RPR a week later, because even though you've treated, you still might get a positive RPR result. And so that was just a case to introduce diagnostics. But I want to mention that to make a diagnosis of syphilis, you have to take into consideration the person's symptoms and signs. You have to take into consideration what are their sexual risks for syphilis, their medical history, have they had syphilis before? And then you have to interpret their serologic tests, which can be challenging because we have limitations of our serologic tests. Most clinical settings are using blood tests to make a diagnosis of syphilis. If you work in an STD clinic, you might have a dark field, and that's what this picture on the right is showing you. It's showing you right here, this is a treponemal pallidum. It has this classic corkscrew motion and shape, but dark field testing is not widely available. It is available at the STD clinic that many of the clinicians who are presenting today have worked at. PCR tests, which are like swabs of the lesion itself, of the ulcer, they are available in some settings in the United States, but none have actually been FDA approved for commercial use. But some laboratories have done tests to allow, they've done validation studies to allow this test to be used. It's most useful for primary syphilis, might be somewhat useful for those lesions of secondary syphilis. But so we're left with our serology. We're left with non-treponemal tests, the RPR being the most common one. And I know that you all are using the RPR. So when I talk about non-treponemal tests, I'm going to be meaning RPR. And then treponemal tests. Take-home message here is you need both types of serologic tests to confirm a diagnosis of syphilis. And now I'm going to talk about in more detail kind of serologies. We'll start with the RPR and the VDRL. This is what the laboratorian is looking at when they're reading out a positive result. This test is a reactive result. You can see the clumping of the charcoal from the lattices that are forming from the antibody-antigen reaction. But the RPR test is actually not a specific test for syphilis. They are detecting a cardiolipin lecithin antigen that can be elevated in patients who have syphilis, but it can also be elevated in other infectious diseases. And that's why you need two tests to make a diagnosis or confirm a diagnosis of syphilis. You need your RPR test, plus you need a treponemal test. The RPR test is very useful because it gives you a titer. And titers are useful to assess the burden of disease as well as to assess the adequacy of treatment. And then there's the challenge of biologic false positives, and that's where you have an RPR test that's positive, but your confirmatory treponemal test is negative. and we'll talk about the various conditions that may take place. So with your RPR test, if you're getting a quantitative test, you're getting a titer. And when you're following a patient for syphilis, you're going to follow them to see, does that titer drop fourfold? Or does that titer rise? And I just want to mention here that in general, we're not concerned about a twofold change because a twofold change can be within the margin of test error. But a fourfold change, a change from 1 to 2 to 1 to 8, a rise, if it was sustained over the course of 2 weeks, that could be significant. It could be a sign of new infection. And you always want to compare an RPR test to an RPR test. The RPR test is often slightly higher than the VDRL. All right, moving on now to treponemal tests. And so I'm going to be focusing on the TPPA because I know that's the test that you use in American Samoa. There are a bunch of other treponemal tests, and there's some automated treponemal tests in the United States. But these treponemal tests do detect specific antibodies to treponemal pallidum. So they're a more specific test. The challenge with the treponemal test is that antibodies can stay positive for life. And so they're not useful for detecting reinfection or response to treatment. And that's what this graphic is showing you here. This graphic is showing a couple things. So in orange, this is our treponemal test, the TPPA. These treponemal antibodies may be detectable slightly earlier than the RPR or the non-treponemal antibodies. And these treponemal antibodies are going to remain positive for life. So they're not a useful test to screen somebody for if they've had syphilis before. The RPR test, after treatment, they often will drop fourfold or more, but many people after treatment will drop their titers but remain serofast, meaning that they have a titer that is in a low-level titer, 1 to 1, 1 to 2, 1 to 4. And I believe that I've covered everything on the right here, so I'm going to move on. I want to talk about syphilis screening algorithms. I know in American Samoa, you're using the traditional algorithm where you start with an RPR. So that's your first line screening test for syphilis. If that test is positive, the lab should automatically do a second test, and that test is the TPPA. And as I said earlier, you need 2 tests to confirm a diagnosis of syphilis. So you had a positive RPR and then had a positive TPPA, this is somebody who has had syphilis, and then you would want to inquire with them and find out, have they ever been treated for syphilis before? You'd want to do a good head-to-toe exam to see are there any clinical findings of syphilis on exam. I want to briefly mention some of the diagnostic challenges. We've already talked about you can have false negatives, and that was our first case, someone who had an RPR that was negative when they were presenting with a genital ulcer. So you can have false negative RPR results in early primary. There's something called the prozone, which is a rare false negative, less than 1%, somewhat more common in neurosyphilis, pregnancy, maybe in early syphilis. But basically, the person is so infectious with syphilis, the amount of antibody that their body is producing overwhelms the antibody-antigen reaction. But here, if you see somebody with a rash that you're thinking, oh, it's just like that lecture I just went to. This looks like a classic syphilitic rash, and you think it really is syphilis, but your RPR is negative, you might check with your lab and make sure they have diluted the serum, and that would be able to determine whether it is truly syphilis or not. And then I want to mention biologic false positive results, and this is where if you're screening somebody for syphilis and you have an RPR that's positive, somewhere around 1.5% of the general population may have RPRs that positive, but then have a treponemal test that's negative. And that's because the RPR test is detecting this cardiolipid lecithin antigen that is not specific to syphilis. And so other concurrent viral illnesses, including HIV, persons of older age, persons maybe with chronic hepatitis or other autoimmune diseases, or persons who are injection drug users may have an RPR that's positive, but then a treponemal test that's negative. These are not patients with syphilis. These are biologic false positive results. Again, just to stress, you need both treponemal and non-treponemal tests. I think I've had 3 or 4 slides that have said this, but that's a really important message to confirm a diagnosis of syphilis. And I want to say that syphilis diagnosis is very challenging. if you haven't seen a case of syphilis, I know this is a lot of information. And Dr. Johnson at the beginning of our presentation shared the STD-CCN website where you can consult with us. And that's going to be a great resource to you all if you end up seeing possible cases of syphilis. So now we're going to move and talk about treatment for syphilis. The mainstay of treatment is benzathine penicillin G. And this is where staging is important. So patients who are staged with primary, secondary, and early latent disease, only one single dose of benzathine penicillin, 2.4 million units IM, is appropriate and adequate treatment. You don't need any other regimens, and you don't, persons who are living with HIV get the same treatment. And I want to mention that Bicillin LA is the trade name. There have been some clinics, mostly a few years ago, where they were using Bicillin CR, and that doesn't contain the same amount of benzathine penicillin. There are alternative regimens that can be used to treat early syphilis in a non-pregnant person if they have documented penicillin allergy. These are somewhat challenging to take because you have to take an oral antibiotic for 2 weeks, doxycycline twice a day for 2 weeks, or tetracycline 4 times a day for 2 weeks. And there's some limited data that ceftriaxone might work in a 10-day regimen. I'm not going to focus at all on treatment in pregnancy. I want to say, but in general, in pregnancy, you're going to treat with a penicillin regimen appropriate for the stage of infection. So it's similar to non-pregnant persons. The only challenge is that if you've got someone who has a history of allergy, penicillin is the only treatment for syphilis. And these women or pregnant people need to be desensitized and treated with penicillin if they've got true penicillin allergy. The other thing I want to mention here is that there is some evidence that in early syphilis, so patients who are staged with primary, secondary, or early latent, that you might want to give that mom not just that one dose of benzathine penicillin, another dose 7 days later. And what I always teach is 1 dose for the mom and 1 dose for the baby. And so that's the only change in a pregnant person, is that you might give them 2 doses for early syphilis. Now, how about treatment for patients who meet criteria for late latent or latent of unknown duration? These are people who have been infected for a longer amount of time, and they get a longer amount of duration of treatment. So benzathine penicillin G, given as a total of 7.2 million units is what the treatment is. And this ends up being 3 doses of that 2.4 at 1-week intervals. And ideally, those intervals are actually 7 days. In a non-pregnant person, 7 to 9 days is ideal. There is anecdotal data that, 10 to 14 days might be okay. In pregnancy, what the CDC says is that the 7-day interval is optimal, and you would have to restart the entire series if a pregnant person's interval was over 9 days. Alternatives in a non-pregnant person are the doxycycline or the tetracycline for 4 weeks for both of these regimens. So challenging regimens to take. And then again, someone who's pregnant, the only regimen that you can treat them with is benzathine penicillin. And then this slide just goes over kind of staging and how staging influences treatment. So patients who are staged with early disease, it's that 1 dose of benzathine penicillin G. Patients who are staged with late latent or latent of unknown duration, they get 3 doses given at 1-week intervals. And then people who meet criteria for neurosyphilis, they have a lumbar puncture that shows that they have neurosyphilis after having an abnormal neuroexam. It's 10 to 14 days of IV aqueous crystalline penicillin G. And at the bottom of the slide, it says always order an RPR on the day of treatment. We're going to talk about that in just a moment, how it's really important to know where you're starting at when you start treatment for someone with syphilis. A couple things related to treatment that patients should be made informed of is that after they get their benzathine penicillin shot, they may go home and they may feel worse before they feel better. And that's because they can have something called the Jarisch-Hersheimer reaction. It's an acute febrile reaction that can occur usually within 2 to 8 hours after treatment. It's not a drug reaction. They can still take benzathine penicillin. It is basically toxins that are being released from the killing of the treponemes. They may get home and they may have headache, myalgias, their rash may become worse. But then within 24 hours, everything should start resolving again. More common in early syphilis than it is in latent. And again, it's not a drug reaction. So day of treatment titer, why is this important? And so the day of treatment titer, when you start treatment for syphilis, you're going to be following patients to see, does that titer drop fourfold? And so say you're screening somebody for syphilis who's presenting with a rash, you're not really thinking that it's syphilis. It ends up being syphilis. And maybe it takes them 10 days to come in and get that treatment, but you forget to get that day of treatment titer. Now, 6 months later, you're looking at titers. It doesn't look as if they've had a change in their titer at all. However, if you'd gotten that day of treatment titer, you would actually be informed that it was the peak titer, but it wasn't checked. And so having a day of treatment titer is important because it establishes your baseline, and that's the titer you're going to follow to see, does the titer drop fourfold. Often this is forgotten, and I always get asked, like, if it's 2 days later, does it matter if they're coming in 2 days after treatment? And now there's actually a study that looked at this where we can that looked specifically at day of treatment titers and the interval between treatment and diagnosis. And so this was a recent study that took place in Melbourne at their sexual health clinic. They followed patients who were diagnosed with syphilis of all stages, almost 800 people, 766 of them. And what they found was that 15% of those patients had either a rise fourfold or a drop fourfold between diagnosis and the day that they got their treatment, so their day of treatment titer. 12%, this is the number I want you to remember, 12% were more than fourfold rises. So 94 patients out of that 766 had a more than fourfold rise. And this occurred at all stages. There were no significant differences by stage. The proportion of fourfold rises increased the longer duration of time. So for those patients who are coming back 1 day later or 3 days later, there were 6% of those people that actually had a fourfold rise. For those patients that were coming back after diagnosis for treatment, if it was a 10 to 14 day interval, 27% of those had a fourfold rise. And that is why getting a day of treatment titer is so important. The longer you wait after diagnosis before you treat, if you don't get another titer, that titer may have already risen fourfold. And that's what this study was showing. And that's what this graph is showing, is that it's very soon after diagnosis. If it's just maybe 1 day, then it's a lot less common that they're going to have a fourfold rise in titer. If it's been more than 7 days, it's up to 27% that might have a fourfold rise in titer. I want to mention the bicillin shortage, which thankfully looks like it's resolving. This is something that many places in the United States have been having to deal with, in that there has been a drug shortage 2023, lasting into 2024. Pfizer, which is the only producer of benzathine penicillin, estimates that there'll be full recovery by December of 2024, and they now actually have kind of the mainstay medicine that's available. And so we're no longer in a shortage. So that's the good news around bicillin, the treatment for syphilis. And then I know that I have a little bit more time left. One case that kind of gets into follow-up and the importance of follow-up and following titers. And so put on your thinking caps. Here we have a patient who was diagnosed with secondary syphilis, and this is the rash that they presented with. This is it's a male patient who's living with HIV. He was initially diagnosed with an RPR that was 1 to 64. It wasn't thought that it was secondary syphilis, and so he didn't get treatment on that very first day. It took 5 days before he got treatment. And then he was seen 1 week later, which is kind of standard follow-up. If someone's got clinical findings of syphilis, you want to see, is that rash improving at 1 week? And then 3 months later, he had an RPR that still was 1 to 64. So the question to you all is, and I know that this is all new information for you, so this is just a technique for kind of teaching this new information, is what do you think? He started with a titer that was 1 to 64. 3 months later, his RPR titer is still 1 to 64, and he's a person who's living with HIV. Do we say, choice A, it's treatment failure, this medicine's not working for him? Choice B, we should be concerned about neurosyphilis, maybe he needs to have a lumbar puncture? Choice C, 3 months might be too early to assess treatment response? Choice D, I want to retreat him now? Or E, none of the above? And so my response to this, and this is what I want to teach you all, is that 3 months really is too early to assess treatment response, and there's a variety of reasons why. So possible reasons for a lack of titer change is, in this patient, inadequate period of observation. It may take out to 12 to 24 months, even in early syphilis, for titers to drop. We want to make sure that his rash is improving at that follow-up visit, and definitely by 3 months. The other thing that's going on in this patient is his he didn't have a day of treatment titer, so his peak titer was not adequately assessed. And then the third thing that's going on with this patient is persons who are living with HIV may have slow treatment response. And so I just want to share what the CDC says in terms of follow-up and serologic response. Patients who are staged with primary and secondary, you want to see those patients back a week later to see whether their symptoms are resolving. Someone who's living with HIV should be seen 3, 6, 9, 12, and 24 months. Someone who's not HIV infected can be seen at 6 and 12 months, but it may take out to 24 months for those titers to drop, or 12 months in someone who's not living with HIV. For patients who are staged with latent infection, these patients, similarly, it may take out to 24 months for titers to drop if they have a titer that was initially higher than 1 to 16. The standard follow-up is 6, 12, and 24 months, or a little bit more frequently in someone who's living with HIV. And then I'm going to conclude and just briefly talk about partner management. So very important if you're diagnosing someone with syphilis is if they have early syphilis, infectious syphilis, that's primary, secondary, or early latent. All of those patients should be reported to your local health department. In California, we use 1 working day. I'm actually not sure what your health department says around syphilis. Is it 1 working day or not? So that's kind of a question to you all. Health departments are very useful in getting partners in to be treated for infectious syphilis. So all contacts to an infectious case, primary, secondary, early latent, because it can take 90 days for the incubation period, they may be infected even if their RPR tests or their treponema tests are negative. And so all of these patients should be treated presumptively. You're going to test them because if their test is positive, then you're making a diagnosis of syphilis. But even if their test is negative, these contacts are going to get treated. In someone who was exposed and it's been more than 90 days before diagnosis, here you can trust those serologic tests. That's because of that 90-day incubation period for syphilis. So if their tests are negative, no treatment is needed. And then long-term sexual contacts to someone who's been staged with late latent syphilis, because late latent syphilis is not thought to be infectious sexually. It still is infectious mother to child, but not infectious sexually. You can evaluate all these partners clinically and serologically. So they should be screened for syphilis using the traditional algorithm with the RPR. And then these patients or these contacts would be treated based on the findings from your exam, as well as from the serologic test results. So my take-home points, syphilis can mimic many other diseases. And so I've shown you a whole bunch of pictures of syphilis. So really keep it in your differential when you're making diagnosis of rashes and when you're making a diagnosis of herpes, when you're making a diagnosis of genital warts. Think about secondary syphilis. And that empiric treatment, if high suspicion, and know the limitations of your diagnostic tests. And that you need both treponemal and non-treponemal tests for your diagnosis, and that day of treatment titer is very important, and that's the titer that you're going to use to assess does that titer drop fourfold in follow-up. We talked about how syphilis staging guides treatment, and that you follow the RPR, and that all cases should be reported to your local health department. I know that you're not seeing a lot of cases, but this is hopefully to prepare you in the future that if syphilis kind of moves your way. Dr. Johnson already shared this resource to you all, the STD-CCN. I just want to highlight it again. It's a great consultation service. And then on our website, we have a couple useful handouts that could be printed out and put up in clinics. This is an algorithm for assessing patients with suspected primary syphilis, an algorithm for patients that you're suspecting might have secondary syphilis. And then these are algorithms how to interpret your serologic results. The one that would be useful to you all is the one here on the left that's in red. And then a couple other resources, our website, the National STD Curriculum, the CDC Guidelines website. And then I believe that I'm done, and I'd be happy to answer any questions.
Thank you so much, Dr. Adler. I am scanning through the chat and the Q&A. I think the only thing I've seen so far, although please feel free, folks, to add more, but there was one provider who was noting that they actually use the reverse sequence algorithm in their setting.
I'm happy to talk about the reverse sequence algorithm. So you're starting with a automated treponemal test. Some of the common ones are the enzyme immunoassay or the chemiluminescence immunoassay. If this test is positive, treponemal test that's positive, the lab should automatically reflex back to the RPR. If the RPR is then positive as well, then here you're in the scenario you're having two tests that are positive for syphilis, a non-treponemal test and a treponemal. It's the same scenario as in the traditional one down here where you have two tests that are positive for syphilis. And then these patients should be assessed about signs or symptoms of syphilis and have a full exam. The challenge with the reverse sequence screening algorithm is when you have someone who's EIA or CIA, one of these automated treponemal antibody tests that's positive, but then when they reflex to the RPR is negative. And that's called discordant results. And that unfortunately happens fairly frequently. And that's because the automated treponemal tests are not as specific as some of the other treponemal tests. And so what the CDC recommends is that you kind of need a tiebreaker. And what your tiebreaker here is a second treponemal test. And the best test here would be the TPPA. So if your second treponemal test is positive, then you have two treponemal tests that are positive for syphilis, a treponemal antibody and a TPPA. And then you're in the same scenario of trying to do an assessment. Is this someone who has had syphilis in the past? If they have no history of syphilis, then they need to be treated for syphilis. And the recommendation is 3 doses of benzathine penicillin because we're assuming they probably have latent syphilis. If the TPPA is negative, then syphilis is really unlikely. Depending on the scenario, if it's someone you're concerned about early syphilis, we might want to repeat your tests in 2 to 4 weeks. But that, we get a lot of questions about the reverse sequence screening algorithm because it sometimes confuses clinicians. And the reason that we switched over to the reverse sequence algorithm wasn't because it helped clinicians, it helped laboratorians. And now we're really understanding, this screening algorithm more. Other questions?
Thanks so much for going over the reverse sequence algorithm. I do not see any more questions in the chat or the Q&A right now. I think in the interest of time, we can turn it over to our second speaker, Dr. Rosalyn Plotzker, who will be covering gonorrhea and chlamydia.
Start with, some basic learning objectives. We're going over gonorrhea and chlamydia. We're going to be talking about the sequelae. I'm actually going to start with a little epi and then get into the pathophysiology. And we're going to end on screening. And one of the reasons is because I really want you to remember the screening recommendations. So please stick around until the end. Okay, so first some epi. This is looking at age of infection. This is the United States in 2022. And you can see chlamydia and gonorrhea side by side. There's a couple differences. One is that chlamydia tends to be more dominant among vaginal and cervical infections. And so you tend to see the rates higher among females and also a little younger in the 20s. Gonorrhea is, and also keep in mind the rates, if you look at the top, the rates for chlamydia go up to 3,700 per 100,000. The rates for gonorrhea go up to 800. So the rates for gonorrhea are actually lower than chlamydia, just for you to keep that in mind. But chlamydia is more common among females, and for gonorrhea, you tend to see it more prevalent among males, and particularly males in their 20s and 30s. This is looking at sexual orientation and gender of sex partner, or gender and gender of sex partner, excuse me. And this is looking at SUN data, which is an STD surveillance network from 2022. And what you can see overall, this is for chlamydia, is that similarly, you see the maroon are men who have sex with men. Men who have sex with women only are in the blue, and then women are in black. And so you can see that men who have sex with women have a higher rate of women only have a higher rate of chlamydia. But I want you to also keep in mind that this is for people who go to STD clinics. And so there's the thinking that women might be going to family planning clinics or their PCP or something like that. But the main point is that you see by age that this is more prevalent in the 20s. For gonorrhea, it's more common among men who have sex with men. And you know, that kind of starts in the teens and then it persists. And again, we see lower numbers for women. We think that might be because there are less women clients at STD clinics. And then finally, looking at race and ethnicity, you can see that this, for both chlamydia and gonorrhea, disproportionately impacts people who are Black or African American compared to the general population. Also, the Native Hawaiian and other Pacific Islanders, it does disproportionately impact that group for chlamydia. And we also see higher rates in Alaska, or excuse me, American Indian and Alaska Native, especially among females. So those are the groups most with higher rates. This doesn't necessarily mean that's the number of cases, but if you are, if you have a group of patients who are Black or African American, for example, a higher proportion will be impacted by chlamydia and gonorrhea. So how do these germs or pathogens infect tissues and then go on to cause disease? So this is a very beautiful diagram of what happens with chlamydia. And essentially, chlamydia outside of the cell is in a state that's called an elementary body. And so this is tiny and it doesn't replicate outside of the cell. It needs to go into the cell in order to replicate. So it's called a non-replicating particle. And this is what you find in the secretions of, for example, vaginal secretions or discharge from the urethra. But essentially this elementary body will attach to a columnar cell, which is in the mucosa, and then it enters the cell and it forms what's called a reticulate body that is able to replicate. And then it replicates and replicates and replicates until about 2 days, when some of those replicating bodies will become the elementary bodies again, or they'll switch back into the EBs or infectious bodies. And then at that point, once most of them are elementary bodies again, it takes another day. Then the cell undergoes lysis, it opens up, and all those elementary bodies escape and they go on to infect other cells. So that's kind of what happens. You get exposed, it takes about 3 days for the process to happen, and then the cell dies and it goes on. So for gonorrhea, this is a really tricky germ. I always joke around that gonorrhea is my least favorite STI. But what it does is it also attaches to different cells. It can also attach to columnar cells. And there are many, many structures that are located on the surface that it can use to attach to the cell. And then it infects those surfaces, not just the genitals. It can also affect the oropharynx, and it can infect the conjunctiva of the eye. And there's all kinds of different things that can facilitate its evasion from the host immune response. So I have them listed here, but basically it is a very, very tricky infection pathologically. And if the immune system tries to eradicate it, it has multiple mechanisms of dodging that. I keep mentioning columnar cells. Here are a couple examples of where they are. For our purposes, think genitals and anus. So I have a couple pictures of a cervix, a urethral meatus. This can go on to cause PID, which I'll talk about, but it can infect all of these different sites. So what happens if you get an infection and then you end up having symptoms? I'm going to start with the urinary tract, and we'll go through each site one by one anatomically. First, urethritis, cervicitis, epididymitis, and orchitis, so essentially the genital urinary tract. For urethritis, and I'm so sorry, there's something that popped up on my screen. For urethritis and cervicitis, they're very similar infections. For both of them, chlamydia and gonorrhea are causes of urethritis and cervicitis. It can also be caused by other STIs like M. genitalium and T. vaginalis or trichomonas. But usually you want to first think chlamydia and gonorrhea. Those are the most common. So chlamydia is responsible for 15 to 40% of what's called non-gonococcal urethritis. And then it's also responsible for somewhere between 11% to half of cervicitis. Okay, so that's about how common chlamydia is. And once you, I'll get to testing in a minute, but basically when you ruled out gonorrhea, which can be done with microscopy, then you want to think about chlamydia as the next possible infection because it's very common. So signs and symptoms of this are pain with urination or dysuria, as well as itchiness. Sometimes the urethra or the tip of the urethra where the urine exits can be itchy. You can also get discharge. The discharge can be clear. It can be mucopurulent. A lot of times, people who have cervicitis can also have urethritis together. And sometimes the cervicitis, because there's inflammation of the cervix, you can have bleeding, you can have some dyspareunia, you can have a little bit of bleeding after sex. Those are all symptoms. So to test for this, you can do point of care testing. And so one option is to do a stain of urethral discharge and look for at least 2 or more white blood cells in an oil immersion. Or you can do at least 5 white blood cells under high-powered field in a low prevalence setting, right? The other option is to use urine, and you can do a leukocyte esterase first thing in the morning, or you can spin the urine and then take the spun sediment and look for at least 10 white blood cells under microscopy. So those are point of care if you have that in your STI clinic. Otherwise, you'll want to send a NAT, and for that you would do a swab. I know that I spoke with Ina and she let me know that you do Gene Expert, which is great. That's another point of care test. Okay, so next, the recommended treatment for this is if you have uncomplicated chlamydia, you can just use doxycycline 100 milligrams POBID for a week, so morning and nighttime for a week. Or for people who are pregnant and can't have doxycycline, you can just give azithromycin, which is just 1 gram in a single dose. And you can see the alternative regimens here. For something that is persistent or the non-gonococcal urethritis comes back, so they come back and they have symptoms again. For that, you could consider treatment failure, although that's pretty rare for chlamydia. It could also be reinfection. And so if you're not worried about reinfection, you could retreat with the initial regimen. You could also consider testing for M. genitalium or trichomonas, which I mentioned earlier. They're not as common, but you know, they're enough that it is worth treating. It's worth testing for them. Okay, I'm going to move on to the epididymitis and orchitis. So if there is an infection that ascends the urethra and infects either the epididymis or the scrotum, or the testicle. So for this, there's a clinical syndrome, and it usually happens within the first 6 weeks of infection. You'll have unilateral testicular pain. So that's one clue, is that the pain is only for one testicle. You can also have hydrocele, you can have swelling. It can be very tender, especially if you feel the epididymis and it's, it's painful for the patient when you palpate. Long-term, you can, if this goes untreated for a long time, there is some evidence that this can cause decreased fertility, especially during the time of infection. And it can also cause chronic pain, and you need to think about testicular torsion in your differential. This does not cause testicular torsion, but when you have pain, that's another thing you should have in mind. So STIs can cause this, chlamydia, gonorrhea, M. genitalium. You also can think about enteric organisms if you have a patient who has insert of anal sex. So for testing, again, you can do point of care, you can do NAT. You also are probably going to want to send a urine bacterial culture, and you don't need to wait until the culture comes back or before the test results. You can treat them based on risk factors. So when you treat them, you want to do coverage for gonorrhea, you want to do coverage for doxycycline. Gonorrhea treatment is listed here, ceftriaxone 500 milligrams IM, and then doxycycline is 100 milligrams PO BID, and this is for 10 days, not 7. So this is what you would want to treat with for epididymis or orchitis. If you have a patient who does have insertive anal sex, then you can also give a regimen where you do the ceftriaxone for gonorrhea coverage, and then you also do levofloxacin instead of the doxycycline. The levo is going to be 500 milligrams, and it's only once a day, but you still want to do a 10-day regimen. So either way, this person will be getting 10 days. If it's somebody who, for whatever reason, you think that gonorrhea is much less likely, for example, if you did your gene expert test and the gonorrhea was negative, or the patient is just, refusing to get the ceftriaxone and you think gonorrhea is less likely, and you only are worried about enteric organisms, then you can give the levofloxacin alone. Okay, chlamydia prostatitis. This is if it ascends all the way to the prostate. In an acute infection, this person will come in and they will have fever and chills. They'll also have scrotal pain and swelling. That can happen during or after sex. They have lower back pain. They have urination symptoms where it's painful. And so, this is something that is a severe and probably rare disease. Like I'm not sure if you've come across this. There's also a little bit of controversy about testing for chlamydial prostatitis because you express the prostatic secretions through the urethra, and you'll also be doing urethral swabs, or you'll be getting urine. And so it's not totally clear if the chlamydia is truly infecting the prostate itself, or if it is chlamydia that's in the urethra but has not actually ascended all the way to the prostate. There's really no way of knowing. I would not recommend doing a biopsy to diagnose this. But that is another complication that can happen in the male reproductive tract. Okay, so there's a question about swabbing versus doing a urine test. So for penile infections, first catch urine is what's considered optimal. And for vaginal swabs, when you have a patient who's able to do a vaginal swab, that's actually the best specimen for collection. I think that from what I remember in a conversation with Ina earlier, you do urine testing for both male and female. If possible, vaginal swabs are what's considered the optimal test for gnats. And the vaginal swab can be collected either by the clinician or by a patient. So patient-collected swabs have been shown to have equivalent sensitivity and specificity. And there is some concern that the urine gnat may detect 10% less chlamydia than a genital swab for a gnat. That is, that's sort of the thinking around that. For urine versus urethral swab, self-collected urethral swabs or meatal swabs are considered to be comparable to the urine or provider-collected urethral swabs. So they're sort of all the same for that. So I think that the first catch urine would make sense versus swabbing the meatus. So that's how we got to there. But that's how we got to that. Okay, so that's all for the genital urinary infections. What about the rectum, and what about the gynecologic reproductive tract? So basically the rectum and the vagina. For this, I want to actually start with a case because we're going over symptomatic presentations. And so for this, there's a patient who has rectal discharge and has perianal lesions that you can see here. So this patient is a 32-year-old man who has sex with men who comes in with discharge and tenesmus or rectal fullness for 2 weeks. He reports condomless receptive anal intercourse. He's had multiple anonymous partners, and on exam, you see these perianal ulcerations. You see some masses that look a little bit like hemorrhoids, and you have bloody, purulent discharge, and that's on anoscopy. So you are able to do an anoscopy. Okay, so here's what you order. You see that there is rectal chlamydia. There was no pharyngeal gonorrhea. There was no rectal gonorrhea, which you also tested for. You do a herpes test and that comes back negative. You very wisely do a syphilis test and that comes back negative, but because there were ulcers, I commend you for doing a syphilis test. And then you do a test for HIV, also negative. Okay. So I want you to think for a minute, what are the next steps here? Are you going to repeat the STI and HIV screen in 3 months? Are you going to do a chlamydia test of cure in 3 to 4 weeks? Are you thinking about LGV, which is lymphogranuloma venereum? And are you going to, oh my gosh, I just realized, I'm so sorry. I skipped a slide when I was puttering around. Okay, so you do these tests, which I just gave you the results for, and you have given presumptive treatment. I'm sorry I didn't say the treatment point, but here's the treatment that you give. So you give ceftriaxone, you give doxycycline, and you give acyclovir. So you don't need to wait for the results to give the treatment for this proctitis. And then when you get the test results back, you find out there's rectal chlamydia, right? Okay, so now that we're back to what do we do next? Are you thinking about LGV? Are you thinking I maybe should extend this doxycycline course to 21 days? And you do want to think about LGV, and definitely you are going to want to repeat testing for STIs in 3 months. But most importantly, you want to extend the doxycycline course. So you gave a week of doxycycline, you know there's rectal chlamydia and there are symptoms. So because you're thinking about LGV, you want to just extend the doxy course to 21 days, okay? So here is the recommended treatment where you are giving ceftriaxone, you gave doxycycline, you gave herpes coverage. This is all for proctitis. But if you're worried about LGV, then you need to extend that coverage for doxycycline for 3 weeks. LGV, the prevalence of LGV in the United States is about 1% of men who have sex with men overall. And this is important. It's estimated that when there is a case of rectal chlamydia, if you are, testing, then anywhere from 6 to 30% of those cases are lymphogranuloma venereum. So it's actually more common than you'd expect. It's usually associated with HIV, hepatitis C, and in terms of behavior, it's related to people who participate in group sex and chemsex. And also those who have a history of syphilis are more likely to be diagnosed with rectal chlamydia, that is LGV. It's caused by the serovars L1, L2, and L3. And interestingly, about 3 out of 4 LGV cases are symptomatic. So our patient was symptomatic. 3 out of 4, and this is the piece of the slide that unfortunately I'm having trouble seeing, but 3 out of 4 chlamydia cases that are not LGV do not have symptoms. So if you have somebody who has asymptomatic rectal chlamydia, it's most likely not going to be LGV. If you have someone who has symptomatic rectal chlamydia, it's more likely more likely to be LGV. Okay. Okay, let me go to the next slide. Okay, so the progression of LGV, this is something that was developed in 2019, and it's something that was published by DeVry in Current Opinion Infectious Disease. I really like it. It outlines the different stages of LGV. So first, what happens is you have a primary lesion, and this is where it inoculates. So usually, kind of like syphilis, it's painless, it heals, it's often unrecognized. In 2 to 6 weeks, that infection will then spread to the lymphatics, and you can have lymphadenopathy. So the typical presentation that is, sort of a characteristic of LGV is having the inguinal lymph nodes have lymphadenopathy. So the lymphadenopathy happens on either side of the inguinal ligament, and it makes what's called a groove sign. Some people say this looks like a coffee bean, but you can see that here. And then another thing that can happen during that stage is hemorrhagic proctitis or proctocolitis, which is what our patient had. If this goes untreated, then it eventually advances to something that's very destructive called stage 3 or chronic lymphadenitis. This can cause things like elephantiasis and lymphedema that is irreversible, or something called frozen pelvis. So it can, if untreated and or misdiagnosed, it can go on to be very difficult for the patient and can have lifelong consequences. It can mimic other conditions. So here are just some examples. The top example is it mimicking rectal lymphoma, a patient being misdiagnosed with rectal lymphoma, another patient being diagnosed with inflammatory bowel disease. And the treatments for these are very involved. And so being misdiagnosed and then mistreated can be it can have bad downstream consequences. So just keep LGV in your mind when you see these symptomatic rectal presentations. In terms of treatment, when do we give 7 days? When do we do 21 days? This is a nice algorithm that was presented about 4 years ago at the STD prevention conference that I really like. It's by Stephen Jordan. And basically the first thing you say is, okay, I have somebody with rectal chlamydia. Are they symptomatic? If the answer is no, then you can go ahead and treat them for regular, 7-day doxycycline chlamydia, so non-LGV chlamydia. If they are symptomatic, then you want to understand what their risk factors are. So do they have a history of syphilis? Do they participate in group or chemsex? Are they living with HIV? If the answer is yes, if they have risk factors for LGV, then you do want to go ahead and treat them with 21 days of doxycycline. You can do LGV testing if you have access to it. And then you do want to do a test of cure, and that's in 4 to 6 weeks. If they are symptomatic, but they don't have any risk factors, then you think, how severe are these risk factors? Is this somebody who has like a little bit of rectal pain, but it's mild rectal pain? Or is this somebody who has severe anal symptoms? They have ulcers, they have discharge. And if they have severe symptoms, then you do want to go ahead and treat them for LGV. Alternatively, you could just do LGV testing, but I think that actually is hard to accomplish in a lot of settings. And it's more likely it's a little easier to just give the 21 days of doxy. If their symptoms are really not severe, if they had like 1 day of mild rectal pain, think maybe they had other causes for their rectal pain. Did they have constipation? Do they have hemorrhoids? Things like that. But if they're not severe symptoms, then you can probably do doxycycline and they'll be fine. Okay, PID. And again, I am not seeing the, oh, there we go. Okay, acute PID. It's hard to diagnose. And that's because PID literally just means pelvic inflammatory disease. It means there's something going on in the pelvis causing inflammation, but the pelvis has many, many structures, and it's a relatively non-specific disease. And so it's hard to diagnose, it's hard to treat. And it's often, as this says, women with PID have subtle or non-specific symptoms. So I want to start first with just showing the gynecologic tract and thinking about what different anatomic structures can be affected by gonorrhea and chlamydia and what other things they could be. So, you have the uterus itself. In addition to infection, pain can be caused by endometritis. It can be caused by fibroids. You can also think, is this pregnancy related? In terms of the tubes and the ovaries, the fallopian tubes and ovaries, there are things like, could this be an ovarian cyst? Could this be ovarian torsion, which is more dramatic? Could there be an ectopic pregnancy? Or there could be salpingitis that's caused by gonorrhea or chlamydia infection. And then also you can have pelvic pain that's caused by bladder infection or even appendicitis. So PID in general can be very, very vague, and the differential is pretty long. So it's kind of, I want you to think of it as like a spectrum of inflammation. And this can be any combination of inflammation of the endometrial lining, of the fallopian tubes, which would cause salpingitis, or even an ovarian abscess, or the peritoneum of the pelvis. Any of these, and any combination of these can be considered PID. The importance of PID is that in the long term, you can have chronic pelvic pain, and it can also cause infertility. And if this is a person who is becoming pregnant in the future, those pregnancies can also have complications. And that's because when the inflammation occurs, you have adhesions that will form in the tissue. So, PID can be caused by gonorrhea and chlamydia. In addition, gonorrhea and chlamydia can cause vaginal discharge, which also has a wide range of causes. So if you see vaginal discharge, keep gonorrhea and chlamydia on your mind, but you also have to consider all of these other things. And so I just have this table here so that you can sort of compare and contrast and see where gonorrhea might differ from a yeast infection or physiologic discharge or BV. And so you can see here that gonorrhea causes cervicitis. One thing that is unique about it is that the discharge is typically mucopurulent as opposed to other discharges. And you can see that they each have like a slightly different texture and appearance. And most definitively is microscopy. And so if you're able to do microscopy, gonorrhea will cause the gram-negative diplococci. Okay. So, I know that my focus is gonorrhea and chlamydia, and it does present with vaginal discharge. So I want you to have that in mind, but also keep these other ones in mind too, which are also quite common. All right. So if you have somebody who presents with, I think there's something strange with my slides. I'm so sorry. All right. I think that there is a slide. Yes, there's a slide that is missing, and I'm so sorry. There was a presentation of a person who came in with pelvic pain, and I think that slide is missing, and I'm not sure where it went. I'm so sorry about that. But let's imagine that there is a patient who comes in and they have pelvic pain, okay, and they have vaginal discharge. So if you do this, if you have a patient who comes into your clinic and they have pelvic pain and they have some vaginal discharge, here are the tests that you could do. So doing a urine dip is appropriate. Just seeing, could this be a UTI? Could this be related to the bladder or the urinary tract? You want to do a pregnancy test to make sure that that person is not pregnant. You could do a rapid HIV test. And if you have access to a microscope, you do a wet mount and you see that there are no gram-negative diplococci on the gram stain. You also don't see any of the other microscopic evidence of trichomonas or clue cells or yeast, and you send out labs. So you send out your vaginal gonorrhea chlamydia test and also trichomonas and BV with your vaginal swab, and you send an RPR. Okay, so here are the tests that, and I'm sorry that was a little awkward, but here are the tests that you would do if you had a patient who did have signs of pelvic inflammatory disease and pelvic pain. So do you treat everybody with pelvic pain for PID while you're waiting for these test results and the results are pending? Or do you need to be kind of specific? So here are the criteria for who gets treated for PID. Younger gynecologic patients are prioritized for treating for PID. Also, if you, in your history taking, find out that there's a risk for an STI, that is something that should also be there. And then also if they are experiencing pelvic or lower abdominal pain. So all three of these should be present if you are thinking, I need to presumptively treat for PID. And in addition to those three things being present, you also either have to show that there is no cause for the illness other than PID that can be identified. So I ruled out a UTI, I ruled out an ectopic pregnancy, or in addition to the three things I mentioned, you have at least one of these other three things. So is there cervical motion tenderness? Is there uterine tenderness or adnexal tenderness? So first three things must be present, and then either you've ruled everything else out or at least one of these gynecologic findings are present, okay? In addition to that, you can support a diagnosis of PID with these. So these different factors. So if they have a fever, if they have cervical discharge, or if the cervix is friable, if you do a speculum exam, if you are able to do microscopy of the vaginal fluid and you see lots and lots of white cells on your saline microscopy, if you do a blood test and you see a higher SED rate or a higher CRP or C-reactive protein, or if you have laboratory documentation of cervical or gonorrhea or chlamydia, all of that is additional evidence that yes, this person has pelvic pain due to PID. Okay, so this is a gonorrhea and chlamydia lecture. Gonorrhea and chlamydia are obviously implicated in PID, and that represents about half of PID cases. They have either positive gonorrhea or positive chlamydia or both. But that means that the other half have something else. So here are some vaginal flora that have been implicated in the past with PID. And then there also are some other ones, CMV, trichomonas, M. hominis, and M. genitalium and ureolyticum are all also associated with PID, okay? But gonorrhea and chlamydia are associated with at least half. So you want to give empiric broad spectrum coverage for the likely pathogen. So that includes gonorrhea and chlamydia, but also the other pathogens that I listed. And there are parenteral and IM and oral regimens. For the mild and moderate, for mild or moderate severity, you can do either the parenteral or the IM and PO regimens. They have a similar efficacy. The one caveat to that is that there haven't been a lot of studies that look at like long-term sequelae. So if you have somebody who has mild or moderate severity and you compare parenteral and the IM oral regimens to each other, they don't look down the line years later to see prevalence of ectopic pregnancy or tubal infertility, for example. So that's the one caveat. Here are the parenteral options. You use a cephalosporin IV. You can use ceftriaxone, cefotetin, cefoxitin. And then in addition to that, you add doxycycline. If you are treating with ceftriaxone, you also want to give metronidazole. For the oral and IM treatment, you can give ceftriaxone, single dose of 500 milligrams IM, that will cover the gonorrhea, plus doxycycline, plus metronidazole. So in all of these regimens, you are giving doxycycline plus metronidazole. And the doxy and the metronidazole are for 14 days. The alternative to doing ceftriaxone IM, you could give cefoxitin 2 grams IM as a single dose and probenecid orally, and that's also as a single dose. You could also do another parenteral third generation cephalosporin, okay? All right, so for IUDs, this comes up sometimes. If you have an IUD, do you need to remove it if someone has a diagnosis of PID? And the answer is no. The only real risk for PID that's associated with someone having an intrauterine contraception or an IUD is about 3 weeks after the insertion of the IUD. So if it's been more than 3 weeks since that IUD was inserted, if this person has had an IUD for a long time, and then they get diagnosed with PID, you do not need to remove the IUD. That said, if you start treatment for someone who has PID and they aren't getting better within 48 to 72 hours, then you could consider removing the IUD as a potential cause of their continued pain. All right, so those are all of the symptomatic presentations for the urinary tract, the male and female reproductive tracts, as well as the rectum. But most infections don't have any symptoms. And so I really want to end with talking about screening, and then I'll talk a little bit about prevention. Here are the recommendations for chlamydia and gonorrhea screening from the CDC. You can see that for women who are sexually active, who are younger than 25 years of age, so 24 or younger, they will be screened for chlamydia and gonorrhea. If you're 25 years or older, they say recommend screening if at risk. If you have had a diagnosis and you've been treated, you want to retest 3 months later. That's to test for reinfection. And then for people who are reporting sexual behaviors and exposure, you could consider doing rectal chlamydia testing. And that's something that you would be tested, you would talk about with the provider. So there isn't a recommendation to test everybody for rectal chlamydia, but it's something that you could do depending on the person's sexual behaviors. For pharyngeal testing, you only want to do that for gonorrhea, okay? For people who are pregnant, similar recommendations. If they're under 25, everybody gets tested. If they are 25 years of age or older and they're at increased risk, then you would want to test them for gonorrhea and chlamydia. You would retest during the 3rd trimester for people who are under 25 or at risk. And then for pregnant people who've had a chlamydia infection, you want to do a test of cure. And for this one, you want to do it 4 weeks after treatment. And then in addition to that, you retest 3 months later, okay? You don't need to do a test of cure for people who have gonorrhea. Okay, for males or for males who have sex with women, there really isn't a lot of evidence for screening heterosexual men who are low risk for infection. If you have a younger patient, you could consider testing them if they were in what's considered a high prevalence area clinically. So someone who's coming to an STI clinic, somebody who's coming to an adolescent health clinic, someone who is being admitted to a correctional facility or booked into a correctional facility, you could consider doing gonorrhea and chlamydia testing there. Chlamydia testing there. Gonorrhea testing is really, we do not have evidence to do routine gonorrhea testing for males who only have sex with women if they're asymptomatic. And that's true even in high prevalence settings. For men who have sex with men, the testing recommendation is at least annually, and that's for all sexually active men who have sex with men, and that's at any site of contact, so urethra and rectum, regardless of reported condom use, for both gonorrhea and chlamydia, and then also testing for pharyngeal gonorrhea as well. And for people who are taking PrEP, for people who are living with HIV, or if they have multiple sex partners, you can increase that frequency to every 3 to 6 months, okay? For people who are transgender or gender diverse, the recommendation is basically to do the screening based on anatomy. And so, for example, if somebody has a cervix and a vagina, you would test them according to that. And you can consider testing at rectal site based on reported sexual behaviors. And for people who are living with HIV, if they are sexually active, you want to screen at the first HIV evaluation, and then after that every year. And you can do more screening as appropriate based on their behaviors and local epidemiology. Okay, so when a screening test is positive, what are the treatment options? Some of these I've already discussed. So you have The recommended regimen for chlamydia, whether it is genital, rectal, or pharyngeal, is doxycycline 100 milligrams twice daily. You could also do azithromycin 1 gram orally in a single dose. Okay, during pregnancy, you want to use azithromycin 1 gram in a single dose as well. And if the pregnant person can't have azithromycin, then you would use amoxicillin, and that's for a week as well. And this is new. This was updated in 2021. In the interest of time, I have some research about this, but I'm just going to summarize it quickly, which is that essentially in the urethra, there was a debate which is better, doxycycline or azithromycin, and here are several studies. In the urethra, they're about comparable, but in the rectum, most of the studies pointed towards doxycycline being a better treatment for rectal chlamydia. And there was a study that was done in Seattle, and it was presented a few years ago at the STD conference, and it basically showed that, in a randomized controlled trial, that doxycycline is definitively better than doxycycline is better than azithromycin for treating rectal chlamydia. Okay, and so doxy was more effective than azithromycin, about 100 versus 3/4 cure, or 91% versus 71% in the intention to treat. Okay, I talked a little bit about testing 3 months after treatment. The reason is to assess for reinfection, and repeat chlamydial infection is very, very common among females. So this study showed that it looked at reinfection rates. This yellow line is the general population, and then there are months after treatment, and you can see the rates of reinfection. So essentially, about 2 months after treatment is when the rate of chlamydia surpasses that of the general population. So that's why you really want to screen within 3 months. So you want to try to screen people. If you don't rescreen, then by about a year out, about a third of people who had chlamydia will be reinfected. And that relationship is quite linear. Okay, reinfection, why does it matter? We just give medication. The reason is because it increases your risk of getting PID, and it increases your risk of ectopic pregnancies. So after the second infection, your risk for PID increases 4-fold. And we talked about all of the downstream effects of PID, and your risk of having an ectopic pregnancy doubles. And if you have 3 chlamydial infections, then your risk of PID increases 6-fold, and you have an ectopic pregnancy risk that's 5 times what it would have been with just a single infection. So this is very important to detect reinfections and treat them soon before they can ascend to become PID or have consequences in pregnancy. Okay, for gonorrhea, if there is a gonorrhea diagnosis, here is the treatment. For patients who are under 330 pounds or 150 kilograms, you give ceftriaxone 500 milligrams IM once, that's it. For patients who are over 330 pounds, you increase that to 1 gram. And again, that's IM 1 time. If you have not excluded chlamydia, so let's say that you do a gram stain, you see gonorrhea, you're waiting for the results for your chlamydia test, you can add doxycycline onto that, and that's 100 milligrams PO/BID for a week. This is, it's not that new now because it's 2024, but this was introduced in 2020. And there were a few things that were happening before that. So the dose was lower, so the dose was increased. We no longer are doing dual coverage. And for patients who have pharyngeal gonorrhea, it's recommended to do a test of cure. And then you do want to start retesting all patients for gonorrhea within 3 months, again, testing for reinfection. Okay. For alternative, you can use Syphilis. It's now 800 milligrams instead of 400 milligrams. And you can see that if there's a cephalosporin allergy, you would want to use gentamicin 240 and then use that with azithromycin 2 grams. However, for pharyngeal gonorrhea specifically, there really isn't an alternative treatment. So you really do want to stick with ceftriaxone for that. Okay, why did we change this? Ceftriaxone will work against gonorrhea as long as the therapeutic concentration is high enough and it exists long enough. So, you know, we think about things like the minimum inhibitory concentration, which is the lowest concentration of an antibiotic needed to kill the bacteria, and how long that is sustained. So for ceftriaxone, you need that to be sustained for somewhere between 20 and 24 hours. And they found that in when we use a 500 milligram dose, it actually is more likely to sustain that therapeutic level. And also higher doses are more likely to treat pharyngeal gonorrhea infections. This is something from the from GISP, which is the gonorrhea isolate project. And this is a national project that's being conducted by the CDC. This is looking at the number of isolates they're collected from around the country that are susceptible versus ones that have a decreased susceptibility. And so just to give you an idea of what's been happening, in 2009, the isolates were, the majority of isolates were susceptible, about 76%. By 2019, this decreased to 45%. Okay, so a lot of this move to doing just to not using azithromycin anymore has to do with antibiotic stewardship as well. So in addition to gonorrhea, we're also seeing decreased susceptibility to azithromycin for other bacteria. And we want to make sure that we reduce the use of azithromycin overall. And so you can see here are other bacteria that are used for azithromycin and are, you know, developing concerns about decreased susceptibility and treatment failure. So if there is treatment failure, then there are, you know, ways to proceed. For suspected gonorrhea treatment failure, you want to consider 2 things. One is that you've treated the person with what's been recommended and their symptoms are continuing, or maybe their symptoms dip down a little bit and then they recur, and there's no chance for re-exposure, right? So that would be indication of treatment failure. Or you have a positive test of cure 7 days after treatment for an anogenital infection or 14 days after for pharyngeal gonorrhea infection. I know that we're running a little short on time, so I'm gonna go through these next couple slides relatively quickly. But just to show you how for treatment failure, when we're thinking about minimum inhibitory concentrations, this is sort of what we've been seeing happen. And so you can see that the, you know, tetracycline has been kind of consistently having minimum inhibitory concentrations that are lower, or the decreased susceptibility. But ciprofloxacin is one that has been rising, and also azithromycin. Okay, ceftriaxone has been relatively reliable, and so is cefixime. Zooming in on this a little bit, you can see that azithromycin has been rising in the past since 2013, basically. And in 2020 is when we said, let's stop using the azithromycin. And, you know, it's a little soon to know if this is a true trend, but it does look like it's starting to dip down in terms of isolates that have decreased susceptibility. And I'm going to just move forward a little bit and skip back to treatment failure. So what do we do when we have treatment failure? How do we proceed? You want to test, and when you test, you want to use both a culture and a gnat. So if you have somebody who you're worried the antibiotic didn't work, you have treatment failure, repeat your gnat, but also do a culture. You also want to retreat them. And if you think that this might just be a reinfection, you can always retreat with ceftriaxone. If you think it's a true treatment failure, then you'll need to use something different. And so you should use gentamicin. and azithromycin. You obviously want to report this to your local health department, ideally within 24 hours, and you want to reach out to partners. And ideally, you want to you want to treat partners within the last 60 days with the same regimen. So you want to test and treat them. And then you want to do a test of cure in 1 to 2 weeks. Culture is preferred. You can also do a NAT, okay? All right, so how do we prevent this? So I have put a QR code up here. There is something called DoxyPep, and I spoke with Ina, and she let me know that this is something that you are in the process of organizing, which is really, really great. So, you know, we know about screening, we know about treatment, we know about condom use. DoxyPep is basically a regimen that is recommended for men who have sex with men and transgender women who have been diagnosed with syphilis, chlamydia, or gonorrhea during the past 12 months. It can also be provided for people who are on PrEP and people who are living with HIV. And basically, what you want to do is, or the way it works is after condomless sex, a patient takes 200 milligrams of doxycycline PO, and they want to do that within 3 days or within 72 hours after condomless sex. So DoxyPep, the full guidelines are here. And there's also expedited partner therapy, which is a nice way to deliver therapy to people who have been exposed. So if you have a patient who has been diagnosed with chlamydia or gonorrhea, you can provide expedited partner therapy to their partners and treat them just based on the exposure itself. Okay, I want to show a little bit of DoxyPep data, and then we'll wrap up. There are 3 main studies, Ipergay, DoxyVac, and DoxyPep. These were all randomized controlled trials, and they compared DoxyPep to none, and most of them looked at populations that were men who have sex with men, and either they were on PrEP or they were living with HIV. And what you can see basically is that this is very effective across all studies. It's very effective for reducing the risk of chlamydia and syphilis. So between 70 to 88% reduction for chlamydia and between 73 to 87% reduction for syphilis. It did decrease, in 2 studies, it decreased gonorrhea by about half. But I wouldn't rely on this for gonorrhea specifically, but it does seem to work well for chlamydia and syphilis. Okay, so who else can get chlamydia? This is my fun fact to end on, that the Australian koala can get chlamydia. However, it is different than the chlamydia that humans get. So do not worry, you will not get chlamydia from a koala. But it's interesting because it's kind of a complicated situation. Koalas rely on bacterial fermentation, and they have very efficient metabolic pathways. And so, you know, they think that it might have a role in their normal physiology. You know, it's kind of tricky, and there's some debate about if I'm blanking on the vaccination piece. I think there might be some vaccination in development for koalas in the veterinary world.
Thank you, Roz, for that very comprehensive talk on gonorrhea and chlamydia. Much appreciated. I have one thing I kind of wanted to talk about around gonorrhea and test of cure. I understand, at least from Ina, excuse me, we know another Ina, from Ina, that typically in American Samoa, you all may not yet be doing extragenital testing for gonorrhea and chlamydia, but if and when that becomes part of your practice, I just kind of want to clarify or talk back through, like, when is a test of cure indicated in gonorrhea? Can you speak to that?
Yeah, I think, you know, so test of cure for gonorrhea, they recommend doing a test of cure for pharyngeal gonorrhea. It doesn't always happen. You know, I think that it's not always followed by the book. I think it's not a bad idea. And ideally it would be, I mean, I think it's a good idea. And it's recommended at 14 days. So
Yeah, that was the point I just wanted to get at. You don't generally need to do a test of cure, but for pharyngeal gonorrhea in particular,
Yeah.
CDC does recommend getting a test of cure. CDC says 7 to 14 days. We feel pretty strongly that you should aim on the 14-day side
Yeah.
of things, because there's a potential that you'll detect like dead genetic organism material.
Yeah,
which
and then you'll drive yourself crazy. Yeah, it's good to wait till 14 days so that it fully clears, and you don't get any false positives.
Exactly.
Yeah.
All right, folks. Well, I don't see any questions in the chat or in the Q&A. I want to thank you all for inviting us to this talk. I want to encourage you to use STD-CCN if you do have cases or other questions for us. And of course, you have Elizabeth Olson, our program manager's email address. And just a reminder to reach out to her directly if you have any issues with CME coming out of this webinar. Thank you all so much.